Good morning, everyone. I'll be presenting on behalf of Medicine 5, Gelid. So history-wise, presenting a 33-year-old female tea from Kupam who came with fever for the past 1.5 months, cough for the past 1 week, weight loss since past 1 month. It's not quantified, but the family noticed that her clothes had become loose and she had lesser and lesser appetite. Baseline activity of daily living, she's been a global developmental child, able to walk around within the house, do few basic chores. Since the age of 3, she's been constantly requiring care. Past history wise, she's a known case of seizure disorder since childhood. She's been under a regular follow-up for the same on two anti-epileptics, carbamazepine and valproate. Recently, she was treated for the same illness elsewhere, first in a government setting, after which she was brought to us for further management. On examination, she was conscious and alert when she came to our OPD. Pulse rate was 72, respiratory of 20, PP of 160, initial temperature of 97. There was no palliative cyanosis, clubbing, or pedal edema, but she had hard left supraclavicular and right cervical lymph nodes, which were palpable. The left one was fixed hard, right one was mobile, which was 2 into 2 firm nodes. The systemic examination, there was no hepatosplenomegaly on abdominal examination. CVS and RS examination were normal. CNS examination was she is conscious, she speaks intermittently, she does communicate with a few words. Intelligence was below normal. Orientation could not be assessed. Cranial nerve examination, how much to which extent she cooperated was within normal. Power was at least 4 by 5. Reflex was were 2 plus. Gait we were unable to assess because she was not cooperating to walk at that point of time. There was no neck stiffness. The skull and spine were normal. So the syndrome complex of a 33-year-old female with a global development delay with fever, cough, lymphadenopathy, loss of weight, and loss of appetite. So we consider differences of tuberculosis primarily. HIV with an opportunistic infections, infectious mononucleosis, lymphoma, SLE, sarcoid, adult onset Still's disease, Kikuchi, and Castleman's as our broad differentials. However, I wouldn't. The focus is not only on the PO part of this. This is a straightforward child with a PO. But in the ward, during the course of the ward, while we were taking care of her, we noticed one small thing. In the ward, initially her temperatures were 97. After which, in the ward, she had developed a temperature which was thermometer was reading as low. It was a non-recordable temperature. Her core temperature was below 92 degrees Celsius. She had developed significant hypothermia. So that is what this chart is I'm trying to show. Her least temperature that we could find out was at around 91 Fahrenheit. So I would like to quickly just go through hypothermia, definition, severity, etiologies, clinical signs and symptoms, and a quick management overview of what we could do from a medical perspective. So any core temperature which is below 95 Fahrenheit is defined as hypothermia. Mild hypothermia, moderate and severe. 90 to 95, mild hypothermia. There are different definitions based on mountain. There is a medicine society of mountain medicine. They have defined it differently because they're the ones doing outside. Wilderness society has a different definition. Our medical society also has a different based on the travel outside and exposure to climate. They have different definitions for this. I have picked up the ones which we use clinically in our hospitals. That's 90 to 95, mild, moderate between 90 to 82 to 90, severe hypothermia of core temperature less than 82. So quickly going through our Harrison's table for risk factors for hypothermia. Who should be developing hypothermia? So elderly, neonates, the age extremes, any environmental exposure, toxicologic or pharmacological agents such as ethanol, antidepressants, benzodiazepines, insufficient fuel, meaning malnutrition, kwashiorkor, endocrine deficiencies like hypothyroidism, hypoproteinism, adrenal insufficiency, neurological issues such as cerebrovascular accident, Parkinson's, multi-system like sepsis, shock. In our child, we were considering malnutrition. I'm sorry, the arrow is towards there. One was malnutrition because the fact that she's been now sick and she's a DDD child who's being cared by other people. The other possibility was hypothyroidism in her, adrenal insufficiency, hypopituitarism also with the underlying GDD. Sepsis was the other condition because she was treated elsewhere and she came with severe hypothermia here. We consider a possibility of sepsis. In the ward after the hypothermia, she also developed shock. So this was the other. So we considered, and the fact that she was immobile and debilitated for the past few months. Coming to the clinical signs and symptoms, based on mild, moderate, and severe, all systems are affected variedly in hypothermia. In mild, there might be amnesia, dysarthria, impaired judgment, maladaptive behavior, and CNS symptoms. As they progress towards a coma, and reflexes start becoming. There is areflexia, including ocular reflex becoming loss of ocular reflex. CVS, initially you notice a mild hypothermia produces a tachycardia, which progresses towards a bradycardia, which we saw in our patient. Initially, she was normal, her heart rates was 70, 80. Her heart rates progressed to fall down to up to 40, 42 with a we documented ECG. And the ECG finding usually we see with this classically described as an Osborne wave, which is a J point elevation, but unfortunately ours had only sinus bradycardia. Then it continues to further cardiac output drops, and finally they're prone to even ventricular fibrillation when they have severe hypothermia. Respiratory wise, they have tachypnea, bronchoria, and bronchospasm. Then progress towards hypoventilation. The moderate ones develop a 50% hypothermia for each 8 drop in temperature. They drop 50% carbon dioxide, excretion starts decreasing. And as they progress to severe, even 75% of the carbon dioxide, they're not able to excrete. So they keep retaining a lot of CO2. The renal and endocrine function wise, initially they have diuresis, and there is actually renal functions are actually increased. All the steroids increase, mild increase in thyroxine, increase in catecholamines, increase diuresis. And this is towards the moderate stage. Now the renal with the concurrent cardiovascular collapse, the renal is also now getting affected. The diuresis now stops. Their renal outflow also decreases. Musculoskeletal wise, initially there will be pre-shivering. There is actually mild increase of muscle tone, but as the hypothermia persists, they tend to fatigue. They just are rigid. They are hyporeflexic, and towards the end, there's a decreased nerve conduction, and there is areflexia. So coming to management, quick management, so it is all about rewarming, passive and active rewarming. So active rewarming actually is more towards a patient who's in a cardiopulmonary arrest, where you can find where the patient has a hypothermia, where you have options, where you go for invasive options such as ECMO, dialysis, or a cardiopulmonary bypass, where you can heat the blood and re-enter. Passive measures, what we can actually do for the patients are covering the patient completely with an insulated blanket, including the head, including the peripheries. There is no evidence for heating the peripheries, because there is again what happens is then there will blood flow towards there, and then they again centrally get hypothermia. So there is no point for that. You completely cover the hot air blankets. We have bear huggers available. Unfortunately, in the wards they are not available, but in ICU and both in our OTs it is available. We can give, if someone is requiring oxygen, heated humidified oxygen. And for our IV fluids, there is a counter current inline option we have in anesthesia and ICU for our patients who have severe hypothermia. So in our just coming back to her case quickly, we had done a lymph node biopsy for her. She turned out to be PB lymphadenitis. Her other evaluation had shown central hypothyroidism also, but her MRI brain did not show a lesion in the pituitary. She was also concurrently on antiepileptics. Both of the antiepileptics had shown some evidence of causing central hypothyroidism as a possibility. Because she had developed significant shock, the cortisol was taken after administration of hydrocortisone. The cortisol is more than 75. We were not sure if there is an adrenal insufficiency, but with replacement of thyroxine, adequate antibiotics, and with septic doses of hydrocortisone, her hypothermia completely resolved. Bradycardia has also resolved. She's actually now started to slowly spike small fever, but she is resolving, probably secondary to the underlying TB. The biopsy has proven the tuberculosis. The excision HPE is also towards tuberculosis itself. So our patient, lymph node TB, it's a multifactorial thing. Medicine is always about, it's a straightforward PO, but there are so many things to be addressed in this patient. Her GDD, her care, TB. Once we have started the ATT, we are struggling with seizure control because rifampicin is downregulating the other drugs. So we are covering with other anti-epileptics and managing that. Hypothermia, we have managed by supplementing the endocrine part, we have sorted, then we have covered, and we are improving her nutrition as of now. Thank you.
Thank you, Dr. Rithesh. Any questions from the floor?
Gelid is a Latin word for ice cold. Ice cold. We didn't give IV thyroxine preparation as such. We just started her on this thing, hydrocortisone with this thing alone. IV thyroxine we had not started. TSH was 1.23. We had sent the T4 FTC after that. We were suspecting. I'm assuming the hypothermia actually pushes the TSH first, and the T4 FTC had not been able to keep up. So central hypothyroidism we had thought of. Two things were the thought. One was she's a GDD patient. So is there an underlying partial hypopituitarism also? The other thing is there's a TB involving central TB. MRI is not showing any features of the same. So we have supplemented thyroxine. She is improved. So we did not initially give this thing. And she quickly improved once the steroids and antibiotics were added. We have not given IV levothyroxine. Hypothermia, multifactorial, ma'am, sepsis, adrenal insufficiency. Yes. Sepsis, there was a bacterial source. We had drawn blood cultures. She was treated in Adkampare for 2 to 3 days over there, after which she had come and become here, had developed this. Most of it fits into something like a mixing of coma. No hypothermia. Is she have hyponatremia? No. No hyponatremia, no non-pitting edema either. Because you cheated. I know. Realizing you didn't give the steroid and you can give it. We did consider the possibility, but we didn't, because she was treated elsewhere. We had to concurrently treat for the. We don't know whether she's required long-term steroids. We are unsure as of now. Once she gets better, maybe we can try withdrawing for 48 hours, resending her cortisol, and then see if she actually requires replacement or not. We have not sent a procal for her.
I think I tend to agree with Esther on this mixed immune part. So, because there's not a general, we see so many sepsis, we see so many, they don't really tip so far, right? And there's something more than, so what would be a clinical takeaway in terms of when would we suspect, or can we catch these guys early so that they don't really go there as, bad a hypothermia as this patient had? Is there any tips we can, because it's not something which happens regularly. We see so much of sepsis in the ward, so much of hypothyroidism. It's not like everyone goes into these stages.
Sure, sir. The initial presentation, she had come to ED once, OPD once. Both of these times, none of these, there was no bradycardia, there was none of those symptoms. So we are not sure if we think it's multifactorial. And there is the first thought was the reason why we supplemented also is because she had significant hypothyroidism.
And then the question about what Kripa was asking, what do you foresee in the long term in terms of, do you think this is just a one-off kind of a thing, which is
we have now supplemented. Now she's not had hypothermia further. Yeah. She's now at baseline and she's having, she has few fever spikes now, but otherwise she's with the supplementation of steroids and this thing, we are okay. Whether she actually requires steroids or not is once her acute illness starts subsiding, we will stop the steroids. After 40, we want to recheck the cortisol, her baseline cortisol, and find out if does she actually have an adrenal insufficiency. Is there a TB involvement? Then the abdominal imaging right now shows no involvement of the adrenals, but we will check for that also.
Thank you, Rithesh. So I think we come to an end of today's clinical meeting. We had a fantastic array of cases being presented over here. Just a few comments from my side. Whenever I think as trainees, you are supposed to be trained as teachers as well, right? There's no special class where you're trained to be teachers. So I think you need to be, whenever you present the slides, any presentation, just make sure that, your slides are kind of, so it's always remember, less is more. You fill your whole slide with, text. So everybody will be just reading that and not really looking at or be attentive to what you present. So I think be careful to, get your slides in order. It gives you as a presenter, you are confident when you present over there. And I think it'd be good if you can, even if it's your colleague, just do a presentation before you come over here. Second thing would be the review of literature. This is something I think we need to be very careful about, because whenever you have a case, you learn from other, cases, and I'm sure there are a lot of things we need to, it's good to have a good review of literature, and at the same time, make sure that you write the references below so that you can always go back and check on them. And space out your, like what I said, space out whatever you write. There are a few slides which are really good that way, and practice like what I said. But the end of all, I think I would really encourage you guys to put this out, like publish this. These cases are like, we keep this, these meetings every month. I really wonder how many of them get published. So I think this is something which we should encourage. Unless Vineet had put up those case series, be it from Pakistan. See, Pakistan has 7 cases. I'm sure you dig in, you'll see more than that. And I think unless we publish, it's no point. It should be a learning, not just for this crowd of maybe 10 or 15. It should go beyond. And that's one of the reasons we have a wonderful array of cases, but unless you put it out, it's of no use. Like, we move out of this room and that's about it. So I think I would certainly encourage you guys to just maybe you have enough and more journals taking case reports, like, BMJ. I think it's a paid journal though, but there are like, if you go in for a case series, you can always put it as a short report or whatever. There's no dearth of journalists who can take these things. So I would certainly encourage you guys to just, whatever you present, make sure that at least, make sure that 2 cases from a clinical meeting gets published, so that it's better for the larger audience, for science in general. So I think that's something which we should push for, especially the faculty members. I would certainly push for at least choose 1 or 2 best or whatever. I mean, like, not that any of these things are bad, but in order to write, I think today's probably Vineet's and Kripa's, all the cases, in fact, there's nothing that stops you from writing it up. And it's not like you have to take 2 days off to, write all these things. It's you have everything on your slides. You just put them together in sentences and push it out. And I think that'll be really helpful. So please consider that from a clinical meeting perspective. It's not just for you. I think it has to go out as well. Right, so I've got a pen here. I was just trying to score these presentations based on time, slides, presentation, and Q&A. And I may be biased, but I think I would like to give this to Vineet. Thank you, Vineet. And not the least, I think I would like to thank Vineet and Manna, who came to cheer for me, I guess. Thank you. Thank you so much. Have a good day.